If everyone will take your seats, we're about to get started. Thank you. If members of the CEPAC would get your web-enabled devices ready, connected to the internet, and if you follow the instructions to get yourself prepared to take the votes, please.
Yeah, I had some cold soda, so.
Once you're prepared, will you just flip up your nameplate so that we know you are all set?
Oh. Yeah, I mean, really. So it's sign in as guest and the ID. Just guaranteed guest. Oh, yeah, that's right. Okay. Right.
Thank you. Brian, you guys have remembered when you've entered the system, you can turn your name cards up. Oops.
Boy, you were fast. Okay, go on still post. Okay.
If all members of the panel will come up and get their name prepared to take the votes.
I didn't get here for the tutorial this morning. Yeah, I think I just got it. Oh, when is I supposed to do this? Yeah, if you're on. Oh, wait a minute. Oh, I got on this morning. Presumably.
They talk more about the evidence, so it makes it easier for them to see.
So,
Yeah, I know. I did bring my chocolate.
I keep getting barred.
Two birds right now. We have
Just so the audience knows, we're having the CEPAC log into the voting mechanism, and they're almost all logged in, at which time they'll put up the voting questions and start discussion.
I mean, they literally begin saying I'm sorry.
And once you're logged in, if you'll just put your nameplate up.
I'm sure they're doing that to me. So, but
Interesting.
yeah.
It's just clinical experts.
I haven't pursued it. No.
So it's cheap to look into things.
It's really interesting. At least once a week. Sending something.
I don't know enough about how the political system to tell you what it's like to work there.
Yeah. Such a hard to guess.
How we doing? Looks like Dora, almost
Yeah, I'm
there?
trying. I did it this morning, so
People from Yale complain bitterly.
I can't get it to
From my
type.
organization, including me, complain bitterly. And I don't know if it's
I can do it on my computer.
they're voting on the questions.
While we're finalizing that process, I just wanted to kind of lay the structure out again. So as we start to debate the evidence as we think about the voting for the CEPAC, in front of you we have the ICER research team leads so that you can ask them questions about the evidence. I may ask them to really quickly summarize and to help point in your evidence summary where the key tables are. We've got the patient representative and we've got the clinical experts from this morning. We also have one who wasn't able to here now. So Jean Marie, would you please introduce yourself? And also if you have any financial involvement with industry, let us know.
Hi, thanks for having me. My name is Jean Marie Perrone. I'm an emergency physician and medical toxicologist and professor at the University of Pennsylvania. And I have no conflicts of interest.
Thanks. Are we all, we have one? Oh, no, that's right, you're ex officio, so we're good to go. Okay, so you can all put down your tent cards now. Since we know.
All right, so I'm going to just do a quick test question so you're all prepared to take votes. The vote should turn up on your screens. The question is, in New Hampshire, residents have an advantage. Who is the only American president to be born in New Hampshire?
Josiah
All right, so we have everyone who has voted. The correct answer, almost everyone got it, is Franklin Pierce. There's a statue outside of the Capitol. All right.
But a shout out to the Josiah Bartlett. My favorite president from New Hampshire.
Voted for him, really.
All right, so that was easy. This is hard. We have voting questions, and we actually have one wrinkle to those that I'll introduce when we get to it. But let me just read this, and then we'll kind of back up and talk about, again, the framing here is really, really tough and very important. So the language is, for a patient being considered for a prescription of an immediate release opioid, is the evidence adequate to demonstrate a reduced risk of abuse for patients using Roxybond versus non-ADF immediate release opioids? Roxybond is the FDA approved but not on the market yet immediate release ADF. A couple of other things I wanted to make clear is the framing of the question, and we could have added the language here, but just to be clear, these are for patients being treated for pain other than cancer related. This is non-cancer pain related. And the question is seeking to ask the CEPAC, in a sense, an artificial question. It is about the patient in front of the clinician. Going forward in time, thinking about that patient. We will talk a lot about diversion, about switching, about the broader effects, and there will even be, again, a question at which we will deal with that explicitly. For now, there's a potential policy relevance to this because this is, A, what some doctors would certainly want to think about, the patient in front of them. Patients might want to have this view considered for them as an individual. And even insurers are often, thinking about the medical necessity for an individual patient. But we will definitely talk about the broader issues. They are not being in any way misplaced. We are going to include them, but in this question, we're focused on the individual patient. So I want to just invite Reiner again to help the CEPAC remember in the briefest way the evidence on which you think they should look, to which you think they should look in making a judgment about this question, and if possible, highlight the tables in the evidence summary where they can find that.
So Roxybond has been approved by the FDA with an ADF label. It's the only immediate release. It's not yet available on the market. The only evidence that, and we have it included sort of as soon as the FDA decision came about, the only evidence that's available, it's a reduction in 12 points, I think, was it the intranasal abuse, if I'm not mistaken. So we have only the pre-market evidence on the visual analog scale for this drug.
And that's on page 5 of your evidence summary.
Yep,
handout.
page 5, yeah.
Reiner, you also have the in vitro evidence that it's difficult to get through a needle. I don't know if that was provided to the committee, but it was provided to the FDA.
Yeah, we did not include any of these tampering studies.
Those are pretty important, I think, for the.
I just want to make sure. I want to make sure people can hear you. Just make sure that microphone's close enough. Go ahead and.
Can you folks hear me?
Yes.
So there, I don't know, Reiner, if you want me. Do you want me to summarize for the group what the evidence was that was presented to the FDA advisory committee on this topic?
I think I just want to explain that when at the beginning of my presentation on the evidence, I said we are not going to present the evidence on the tampering studies. So can a drug be put into powder? Can it be extracted? Can it be syringed? Things like that. So the evidence we presented, and that was included in the report, was the evidence on the clinical abuse potential being done in the recreative drug users, and we presented the post-market evidence. We did not present any evidence on the ADFs, on these manipulation studies and the tampering studies, including what Dr. Katz referred to as the syringeability.
So that's a missing piece, and the bottom line is that it's extremely difficult to dissolve this particular formulation and then squeeze it through a needle because they're designed to gel when they're put in solution. So it would make intravenous abuse extremely difficult. And then you heard about the snorting study that you did receive some information about.
All right, questions from the council? Yes.
Yeah, can you help me understand how this intranasal abuse study was done? For example, the participants in the study, what exactly are they provided? Is it the drug in its original form, or is it already turned into some kind of powder, or what do they have to do? And then, therefore, what does liking the drug mean for abuse of the drug? How do we connect that dot?
I mean, the drug, they don't have to manipulate the drug. The drug is presented in powder form, right?
Okay.
Then you're not asking them to do the actual thing. If you go into the internet, you will find lots of instructions on how to do so, but the participants are presented with the drug in powder form.
Okay, so I'm failing to see the connection between this study and its as a test of abuse deterrence. It's just a test of liking the drug once it's in powder form. Correct?
Maybe Nep, you want to comment on that?
Yeah, I can give a little more information about that. So these human intranasal abuse deterrent studies are done in two phases. Phase number one is somebody has to sit in a laboratory and figure out how to get it to its so-called maximally manipulated form. And a huge amount of effort goes into figuring out what's the closest you can get to a snortable powder. If the closest you can get is syrup or chunks or something like that, that's what's going to be presented to these people to snort, whether they like it or not. And if you can in fact get it to a snortable powder, well then that's what's going to be presented to these people. That whole phase one, you forget about that when you go to phase two, which is, okay, here are these different things. It's a multi-period within patient crossover design. You snort whatever you get, and then you rate the drug liking over time. And so those ratings of drug liking are taken as a predictor of future real-world abuse of a drug, and there are reasons why it's believed that does predict real-world abuse, although a lot of debate about how good those predictions are. But the first part about how much effort it took to actually get it to that maximally manipulated form, that's pushed aside. And so the reason that that's felt to be relevant to real-world abuse by snorting is because, first of all, you have to go through some effort to get it to its maximally manipulated form. And secondly, to the extent you believe that drug liking predicts real-world abuse, which there's reason to believe it does, that will give you some sense of how much it will be abused out there in the real world. Does that answer your question?
Yes, it raises others, but it doesn't.
One thing in your question I just want to make sure the council is aware of is that the patients or the individuals who are recruited for these studies, for this one in particular, I'm sure they were recreational drug users. So the question of, again, what the likability within that cohort and its effect on abuse within the broader set of patients who are prescribed. It's always an issue that comes up.
I can comment on that also. There's a reason why those studies are done that way. It's not by accident. And these study designs have been honed over about a 70-year period of time by a lot of very committed people. So it's not an accident. And the reason is because you can't do those studies in people who don't already abuse the drug. You don't see a signal there. And the reason is because the majority of people presented in opioid don't actually experience drug liking. So the feeling of the addiction research community, I don't do these studies, is that it's the liking among this vulnerable cohort that then predicts abuse out there in the real world by similar such individuals.
Other questions from CEPAC? Brian?
Yeah, Steve, this may be a little bit facetious almost, but you're asking us to make a decision about the patient who's in front of us, or a patient who's in front of us. Can you give us any more information about that patient? Because I do think some physicians might alter their thinking depending on, and I realize that CDC said those scales may be unreliable, but...
Right. So I know what you're alluding to. You're alluding to whether the physician thinks there's a high or relatively high risk of abuse in the individual patient in front of her or him. I'm not going to answer your question. I think the goal here is to try to, unfortunately, we will talk about stratification, risk stratification, where the evidence is and where we can go forward. But for now, I think we just have to assume that we're talking about, I hate to say it, but the average patient. But it is one for whom the clinician has determined that it is reasonable to treat potentially with Roxybond or a non-ADF immediate release opioid. Greg?
So, Steve or Reiner, could you remind us statistically what is the likelihood that this patient you're presenting us with would go on to abuse?
Reiner? I'm sure the clinical experts as well, but...
You mean that any patients who receive
an immediate release
would be going on to abuse? There are several studies on that, but maybe Nat, I would like you to answer that. Or Jean-Marie, maybe also.
There are a number of studies. Nobody knows exactly the answer to your question. Probably the range is between 5% and 40%, depending upon which study you read. We don't really have any great long-term prospective outcome studies, but the best one that was ever done, which was published by Edgar Adams in 2006, which was an 11,000 patient prospective study, not a small study, found an incidence of abuse of hydrocodone of 4.8%. So that's the best number, 1 year prospective incidence of abuse of a prescription opioid.
There was also some studies that came across that patients who are prescribed an opioid for the first time, for short term, about 10% of patients go on and take them longer for 3 months. Of those 10%, a quarter may begin non-medical use and 10% become addicted. So these are some of these figures that are floating around on the naive patients. That's why all the guidelines try to limit the prescription time, as well as, first of all, does the patient really need the opioid, or can something else be taken?
Claudia?
And I guess this has to do with this question, plus with oxycodone. Is there what kind of evidence do we have for the individual patient that if the patient is prescribed an ADF versus a non-ADF, that there is a difference in the risk of going on to abuse with a specific patient?
We do not have any studies on this type that show that a cohort receiving for a first time an opioid versus ADF versus non-ADF, what's the impact? We don't have anything that I came across.
Right.
Could I just make one quick
Yes, sure.
comment?
Yes, please.
First is a question. For I think Dr. Bankin, you referred to is it naive patient? What is your definition of that individual?
Your question is very interesting because I don't think there are very good definitions around this. Naive patients, for how many months? Never in life. It's something sort of, it's not very clear in the literature.
Okay, and then just a comment, and it was based off of the pie chart that we saw earlier this morning. It showed individuals who kept using the ADF OxyContin, but I think what we need to keep in mind, too, is that there isn't a study that was presented, and I didn't hear anyone mention the difference between addiction versus dependency. And I think that that's important just to keep in the back of our minds as we continue this afternoon, because some of those individuals in that pie chart may have been misrepresented as being those who are abusing or have an addiction disease versus those whose bodies are legitimately breaking down that medication and are dependent on it for a better quality of life.
Point well taken. We'll return to that. All right. We're cannibalizing the policy roundtable, but we need to flesh out your questions. So let's, Jean.
Well, and this may be one that gets turfed to that because my questions usually end up there anyway. But in the context of a clinician with a patient, the patient themselves might not be at risk of abuse, but they might be in a milieu that would lend that prescription to be more likely to be diverted either through their surroundings or family members. There's no instrument. The CDC has not given us any guidelines for how to handle that, but I can envision my clinician friends trying to sort that out.
Coming back to that at the policy roundtable. And for now, this vote, just so hopefully you guys are all thinking the same way, it's to try the artificial thought exercise of applying your consideration to the individual patient, not considerations about who's going to get into the medicine chest and other things.
And not thinking about price.
Oh, absolutely not. This is about reduced risk of abuse for those individual patients prescribed an intermediate release. I would like, what we do sometimes is before we vote, I invite someone who's going to vote yes and someone who's going to vote no to share some of their thoughts, just to make sure that we have a kind of stirring of the pot here. Nat, yes?
I don't know if this is going to be helpful or harmful to your efforts now, but the formulations are not designed to deter abuse. They're designed to deter abuse by tampering,
right.
Intravenous abuse and nasal abuse primarily. Yet the question kind of conflates all that together with oral abuse, that the formulations are not necessarily designed to deter. So does that help? Would it help the group, I wonder, to clarify the question in that regard and focus on whether the formulations appear to be successful at deterring abuse by tampering as opposed to overall abuse, or does that actually make your life more difficult?
I think I would just want them to include all the different possible routes of abuse within this, so that if there are, I mean, it doesn't have to hit all of the targets for abuse, but if it hits some, I mean, basically that's, if it's going to reduce the overall risk of abuse in the kind of more broad umbrella that you just described, that's what I would.
So if somebody were to believe that the formulations do deter intravenous and nasal abuse, but don't believe that they would deter oral abuse, how would they vote on this question?
If they feel that it reduces the risk of abuse for the prescribed individual of any of those?
Any.
Yes.
Then they would vote yes.
Yes. If they feel the evidence is adequate. That's the other key part of the question usually, or always. All right, so wrestle with this. I would invite you not to vote until you've heard at least some discussion of other people's thinkings before the vote, and you can always change your vote until we show it. Anybody who's preparing to vote yes, would you like to share your reasoning with the CEPAC? Jean.
I'm surprising myself by a yes vote, but I do feel like an option for people who need an immediate release drug is important. And even though I think the evidence is really, really slim, it is approved for this, and so I'm going to vote yes.
Anybody who's preparing to vote no wish to share their perspective? Austin?
Yeah, I'll do it since someone else will. The only evidence presented is on nasal use, not all forms of use, though it did suggest that maybe there'd be reduced abuse in that domain. It's just one study, and it didn't include, again, the full range of possible ways it might be abused. So I think I have to vote no on the adequacy of the evidence aspect of this question.
And to add to that, I think Reiner had made the comment about oxycodone, where 2/3 of the time it's oral abuse by swallowing, and that study was only on intranasal.
Okay, other complementary or contradictory views on yes or no votes? Okay, then if we're all ready to vote, please go ahead and vote. When I get up to the full allotment, we'll show the responses to the audience. All right, 10 no and 2 yes. All right, let's keep going so we can move to the other voting questions and make sure we have as much time as possible for the policy roundtable. The next question is the same framing, different drug. This is about is the evidence adequate to demonstrate a reduced risk of abuse for patients using OxyContin versus non-ADF extended release opioid? Reiner, can you again briefly summarize the extant evidence and where it's in the evidence summary?
All the evidence we showed you, real-world evidence, is related to OxyContin. So we had some discussions about the pre-market studies as opposed to the post-market real-world evidence. So if there is some evidence, it's definitely strongest for OxyContin because we have the evidence on all the different outcomes that I presented.
I found it. It's pages 6 and 7 in your evidence summary are the tables from the main report.
Yep.
Page 6 is the pre-market likability studies, and page 7 is a table of all the different, or I hope it's all of the different post-market studies from different sources. All right, questions from you all? I think we've talked about the framing. Maybe you have specific questions about these studies on this particular formulation? Can I invite the clinical experts, your comment on, again, if you were just answering a question about the adequacy of the evidence for OxyContin. I know we've just walked through Roxybond, but for OxyContin, how would you characterize the differences? Bernie?
I think the differences are small, but I think that there are differences. And it's primarily, it's not oral, it's tampering.
Any questions from CEPAC? Jason?
I had a question related to some of the methodologies involved in the evidence that's presented. So in general, whenever, in any kind of observational data, when you're trying to understand what did an event, in this case the reformulation of OxyContin, do to an outcome, in this case abuse, it's always, no matter what you're looking at, confounded by historical trends, which is to say something else could have been going on in the world that could have confounded you. It's not sufficient to say it's lower afterwards. That's true with all sorts of observational data. So I guess in your expert opinion, my understanding is that there's some, there have been attempts, at least in the historical experience of OxyContin, to disentangle that confounding. Do you view those methodological attempts as adequate for disentangling the confounding? And as such, should that give us more confidence that the reformulation of OxyContin was actually associated with a decrease in abuse for the patients taking that medication?
Well, the main way methodologically that was approached is to look at the contemporaneous rates of abuse of the other opioids that were going on at the same time. So you'd think that if there was some kind of secular trend, whether it's the CDC guidelines or whatever, they would affect all the opioids, maybe not exactly equally, but roughly. And the rates of abuse across, more than a dozen studies of all the other opioids tended to remain either stable or increase at the same time that OxyContin was decreasing, and that inflection node occurred right at the time of the reformulation. So it seems pretty convincing to me.
I just think there's so many confounding things, so many temporal trends. It's very unfortunate that we have not had a well-done clinical trial to actually test this. And given the magnitude of the opioid epidemic in this country, in my view, it's unconscionable that we haven't done it. What confuses me is when we look at these tamper-resistant, long-acting opioids, the fact of the matter is that almost all chronic pain patients who are on a long-acting opioid are getting a short-acting opioid. That's what the pain guidelines all say. You need it for breakthrough pain. And so if someone gets a tamper-resistant long-acting opioid, but they've got 240 short-acting oxycodones and they want to snort, they're not going to, it's pretty easy. So and things like that, the fact that we don't have a short-acting tamper-resistant, I hate the name abuse deterrent, the fact that we don't have a tamper-resistant, I don't know how you disentangle that, because they have it available.
For OxyContin, do we know the frequency of abuse by route? Is it more likely to be swallowed versus intranasal versus, do we know that?
We do. In fact, when you asked that same question earlier, I emailed you a paper that summarizes all that information, which is sitting right in your smartphone probably right now. It's not in yours. It's just in hers. It depends what population you're talking about and the sort of the masses of people out there, most of whom are very casual opioid abusers. The rate of abuse by tampering is low. I don't know what the percent is. Maybe Rick, as you get towards people in substance abuse treatment who are more advanced abusers, then you get to numbers like 50, 60, 70% are abusing either by snorting or by injection. So it's quite high once you get to the point of somebody having an advanced substance abuse disorder. Rick, do you want to add anything to that?
We have looked at several studies of OxyContin. Both oral and nasal and intravenous, all three went down. The nasal and intravenous went down by far the most. And oral went down, which somewhat surprised us, but we think it's mostly people switching, but that definitely happened.
Claudia.
I have a question in interpretation of this question that you're asking. When you're saying reduced risk of abuse, do you mean specifically abuse of OxyContin, or do you mean reducing the risk of abuse of narcotics, which would include changing to an alternative mode?
I would interpret more the former, because in a sense, and the language here isn't in the question, and I probably should have mentioned it, I think you can envision this as a patient who's naive is perhaps a difficult word, but someone who's getting a first prescription, at least for some time, of an opioid. So it would be viewed as the risk of abuse with that drug versus if you had prescribed a non-ADF version. All right. Any other questions or comments? All right, then quickly again, anybody going to vote? I'll start with the no's this time. Anybody want to say if and why they're voting no? Shy crowd here. Yes? I'll shift to yes then. Anybody going to vote yes this time? Yes. Ed.
Even though I wouldn't be terribly impressed with the evidence at another
Sorry, can you lean forward just a little closer?
Even though I wouldn't be terribly impressed with the evidence at another meeting, it looks pretty good in this context.
Other thoughts? You guys I know are wrestling with this. Some of you have already decided yes and some of no.
Yeah.
Anything else? Jason?
Could I just comment? I think just referencing my earlier question, which I appreciate the very thoughtful and helpful responses, Dr. Good's response resonated with me that this is such a big problem in America. We should have a properly designed randomized control trial. So that really hit me. It resonates with me. But that being said, we have to make clinical decisions every day. I have to vote in a moment. And so I would just say that in my voting yes, that expresses that I'm impressed by the historical trend and the degree of, while it is confounded by historical trends, there have been pretty good attempts to disentangle that confounding. I'm a clinical cardiologist. I think that smoking causes heart attacks. There has never been a randomized control trial, but sometimes the best you have is observational data, and to me it meets that threshold as worded in the question.
I think, again, though, we need to state, and we say this at every meeting, but we always forget, that we're not saying, if we say no, we're not saying that they don't reduce the risk. We're just saying that there's not the evidence to demonstrate that yet.
Well, and
So,
I was going to say that sometimes a lot of clinical decisions you make, you know there may not be adequate evidence, but you may still say, well, there's not evidence against it, and there may be evidence, so we're going to give this to you. And I think actually there's a lot of clinical decisions that fall in that category. But the question is not just what you would do with a patient in front of you, but is there adequate evidence? Is the evidence adequate to make this decision? So that's what I think is the quagmire for me is it's in that very murky area.
Right. I think in this case we do have enough bad studies, if you will, not bad studies, but perhaps incomplete studies that add up to being a reasonably good study. You know, we start talking about meta-analysis, and yes, there's lots of games with statistics and not always right, but when you start to see a trend over multiple studies, and as I think it was Nat mentioned, multiple countries, multiple times, or perhaps if someone else would mention that, but you start to look at them in all those different places. I think, Jason, your allusion to smoking is not unreasonable, that we've seen a lot of stuff over a lot of time that smoking in lung and heart disease isn't good. I think we're beginning to see enough evidence here that I would say adequate, so I would vote yes.
Greg?
But I would ask Jason, what if we were talking about heart failure, new drug for heart failure? Would this kind of observational data be sufficient for you to roll into practice, put into the guidelines, a new drug for heart failure based on a before and after study?
Yeah, I mean, Dr. Kirkman, that is a fantastic question, and no doubt informed by your years at the New England Journal where you evaluated these studies. I guess I would just say that I think that's a very compelling point, and I would have to admit no. But the difference in that case is that as a clinical cardiologist, I'm not used to the introduction of heart failure drugs into clinical practice without randomized control trials. And so I think that's an incredibly provocative question, very thoughtful, and I admit the answer is no, but I still am going to maintain my yes vote. And the reason I'm saying no is because as a cardiologist, I am used to randomized control trials always informing the utility of these medications before I have access to them.
Jane?
So as has also been said in these meetings before, a yes vote does not endorse that no further research is needed.
Right.
All right, I'm seeing a certain sense of the crowd that it's time to vote, so let's go ahead and do so. If you previously voted and you want to change, do it now. There we go. 9 yes, 3 no. All right, I appreciate the conversation before the vote. I think we can move on and not need to debrief any further. We've got 2 more votes coming up in this phase before the last vote, which will be taken after the policy roundtable. This last one, we addressed some of the language around this through comments earlier by one of the manufacturers. The question reads, for a patient being considered for a prescription of an extended release opioid, is the evidence adequate to demonstrate a reduced risk of abuse for patients using all other ADFs, excluding OxyContin, versus non-ADF extended release opioids? So here, clearly a choice has been made to lump all the other non-ADFs today with their existing databases, all the other ADFs with their existing databases, acknowledging that they have different mechanisms of action. So the question really is about everything other than OxyContin, the vote you just took, individual patient, new prescription. Is the evidence adequate to demonstrate a reduced risk for other ADFs? Reiner, another brief summary perhaps of what's there?
The question is why we separated the immediate release from the extended release, because that's what we have done. For these questions, the ADF, non-OxyContin, we are talking about the extended release. The first question was about the immediate release. The evidence is the same. It's about pre-market studies. neither Roxybond, neither the non-OxyContin ADFs do not have any real-world evidence up to now. I think the reason why we separated both is because in some way you may think about extended release being more similar between OxyContin and these other extended release as opposed to immediate release. The way of there's no dose dumping with immediate release, in this case there is a dose dumping. So the evidence is the same, it's only pre-market evidence, but I think there is a difference between the pre-market evidence for immediate release and extended release. The data are in page 10 and 11, but it's all these different results about the pre-market studies.
Clinical experts, is there anything that stands out about the likability study, since we're back into that type of study to make this judgment for the council? Is there anything, I guess, notable or distinctive about these likability studies that you wanted to highlight for them?
Well, the evidence is similar for all the products, not identical, but similar in that you've got the in vitro data showing that you can't squeeze these things through a syringe, and that's pretty much all you can do pre-marketing. You can't inject human beings with non-approved formulations, so that's really all you can do. And then you have the clinical trials similar to the other human abuse liability trials that generally show that if you crush one of these things up and give them to somebody to snort, it'll produce lower drug liking scores than these non-abuse deterrent formulations. And some of them have oral studies as well, where you basically do the same thing. You try to crush it up and give it to someone to swallow and measure the drug liking, and you generally see lower drug liking scores than some comparator non-abuse deterrent formulation. That's pretty much what the evidence is for the non-OxyContin abuse deterrent extended release formulations.
I have a question. So because these studies are done where the drug is presented to the patient, to the trial subject, isn't there some other factor that would be the ratio of how long it took them to get to that product, to sort of the ratio of did it take me 20 hours to do this versus 15 minutes? And I feel like I've seen that in the FDA advisory committee data, because that does, I think, factor in a little bit to how tamper resistant they really are.
Yeah, that's a really good question. So if it took you 20 hours to maximally manipulate some formulation and then you snorted it in a study, the fact that it took you 20 hours is not taken into account at all in how those studies are presented. So to the extent that there is that difficulty in manipulation, those studies underestimate the difficulty of that these abusers would face trying to abuse these formulations.
So I guess that might add to their deterrent factor.
Yes.
But you can't distinguish relatively.
Right, you can't distinguish.
Exactly. That does add to their deterrent factor, but it doesn't show up in the drug liking scores because they've already received the manipulated drug at that point.
And I'm sure it's always true. When we heard a lot about the different mechanisms through which people have been able to figure out how to tamper with tamper-resistant formulations. And it may just be that over time, especially if the need is higher because there are fewer non-ADFs available, I assume it's always possible that they'll figure out more efficient ways of tampering over time.
And people have been taking acetaminophen out of mixed formulations forever with recipes and had a lot of experience doing that. Not always so successfully, but certainly there was a chemistry and information sharing going on with that.
Okay, thanks. Austin?
So as we've already discussed, we don't have great data on OxyContin, but we have better data than we have for these drugs. Right. But I'm wondering if I should take the OxyContin data and forget about it in answering this question, or do I reason by analogy? And so we have to decide on that. And if yes, reason by analogy, then I'd want to know what can the experts tell me about the similarity of these non-OxyContin drugs to OxyContin, and how good is that analogy? So it's like a two-part,
very complicated question. A good one. Might as well.
I mean, that's sort of what I'm trying to say, is do we know how hard it has been for them to manipulate OxyContin versus these newer drugs? And I think that's what you need in the real world evidence. Maybe these are going to take 20 hours and OxyContin only took an hour. And I think that's one of the unanswered questions about how abuse deterrent they might actually be.
Well, can I ask you, is the exact mechanism through which OxyContin was made ADF mimicked by any of the other existing ADFs, the exact same way, which would be the closest to your question, I think, of how can we assume that the effects we see with OxyContin applicable to others.
No, not really. I don't think you can assume that any of these formulations are the same. What you'd love to see is some published comparative study looking at the tamperability or extractability in the laboratory of all these formulations side by side, and that does not exist. I've tried, but it doesn't exist yet. So there's no evidence-based public domain data that you can rely upon to make those comparisons. I can tell you, having just seen a lot of the data from these different formulations, you may want to comment as well at FDA advisory committees and all sorts of other places. In my opinion, the non-OxyContin formulations have at least the same degree of laboratory abuse deterrence or tamper resistance as the reformulated OxyContin does. That's just my opinion, having seen a lot of the data.
And that's remark about the public information. I think it's very important because the FDA does not release this information. So you don't get, if you do this, it will take you that long to get the result because they do not want to provide any recipe in there. So I have listened into some advisory committee meetings, and the only information there was on Opana. It seems that Opana, you do some browning to get it ready to inject, right? It's the first time ever I heard any kind of recipe in an advisory committee meeting on how you could manipulate that. So the information on how you did it, how you can do it, is not available. So we are unable to figure this into the manipulation part, into this abuse potential part.
Yeah, I mean, I think Nat is right. I participated in 2 at least of these, but there's never a comparison, and what you really need is all of them plus the comparison to OxyContin in terms of how difficult it is, and you might be able to get that from Blue Light and other websites that describe recipes, but it's not in real data that we've looked at.
All right. Any other questions from the CEPAC? I think I'm going to pass on the discussion of the yes and no's, partly because this follows the template around which we've already talked about a fair amount. So if you don't have any further questions, ready to vote? Okay. $11 no and 1 yes. All right. And I think the reasons are likely to have followed the rationales that were given around your first vote on Roxybond, which I think was kind of a similar setting, if you will, around evidence. Okay. So we have one more question now that we want to introduce. This was not part of the pre-established voting questions, but again, part of what we can do is to think broadly about the flow of the discussion and some of the policy aspects that have been raised even by the public comments presented here today. And so, let's see, Yes, this is the question. So we've, again, artificially framed in some ways these first votes to think about the individual patient. And as I said, that was not to somehow ignore the very real aspects of diversion and switching and other effects in the population once a drug is used for an individual patient. That will really be the heart of what we talk about in the roundtable. We decided to try a vote as well, just to kind of get us kicked off for that discussion. So the vote is worded this way. For a patient being considered for a prescription of an extended-release opioid, is the evidence adequate to demonstrate a net health benefit on a population level with the use of OxyContin versus non-ADF extended-release opioids? We focused on OxyContin because that is the one that has post-market data available. So we thought it would perhaps, again, provide a stimulus to further thinking, but would also make sure that the votes incorporate the fact that we all want to think about the population level aspects of these prescriptions. So questions so just to be clear again, the population level, so now we're not just thinking about the individual patient being prescribed first, that patient is still there, but we really are thinking about the kind of balance, if you will, or how balanced it is or not balanced, effects of diversion, effects of use by others, switching, by patients who are otherwise not being prescribed OxyContin but might have been using it illicitly. All of those different messy intersecting features of what happens in the real world. So I know that this is, again, probably in some ways best set up for a broader discussion on the policy roundtable. We thought we would try a vote. Do you guys have any questions about the evidence related to this question? Greg.
Well, the operative term for me in this question is health benefits.
All right.
And that's different from the other questions where
Correct.
the term was abuse.
Correct.
So this is a much broader outcome. I mean, this is a real outcome. And so I hope we'd all be thinking about that and whether, is there really evidence of a health benefit broadly defined? There are multiple components to the definition of health benefit, the way I think about it. So that's the way I'll be thinking about answering this question.
Right. And again, just to be clear, costs, value, not part of your thinking for this question. We'll talk about that as part of the policy roundtable. This is just health benefit for the population.
Yeah.
And the reason, again, we couldn't just say reduced risk of abuse because that's a small piece of the bigger pie when we're talking about the population. There are all these other effects, their effect on health, which I know it still can be seen as amorphous, but I think that hopefully gives you some framework to think. Yes, Steph?
Should we consider this in the context of...
Can you pull a little closer?
Should we consider net benefit to include economics?
No.
Okay.
Just health benefits, the good and the bad health benefits. Dora?
And I understand that you were trying to get us to tease out and exclude cost issues, but it just seems like from a public health standpoint, if there, the number of dollars, the health dollars, there are a limited number of health dollars overall. So yeah, there might be some net.
Coming to a screen near you.
I know. I just think about the cost that this would and what it could be used for otherwise.
Just take it.
Okay.
Health benefits, starting an important place to start. Austin.
So in this context, I want to get one thing on the record, that if our vote ends up suggesting that we don't think OxyContin has or there's evidence of a net health benefit, one piece of context is that the fault, if you will, or the reason for that may not be OxyContin itself, but the context in which it's provided. Namely, we don't have good controls over heroin, fentanyl, and all manner of other issues at play here. So I just want to make sure that full context is reflected somehow in the report and our comments.
Okay, so noted. And actually, I forgot, I was going to note on the last question, just to be absolutely clear, you guys, CEPAC, are used to this, but when the vote says inadequate evidence, that almost always, actually, it very frequently means that there isn't evidence. It doesn't mean that there's a lot of evidence and it is flawed deeply or somehow contradictory or something else. So here again, when you say, is the evidence adequate, a no vote can mean that there just isn't any. It can mean that there is, but it does not demonstrate a net health benefit, or some combination of the two. I know it's a tough shift of perspective to think around. Any other questions? I'm actually not going to invite comment from the clinical experts because it's going to be the meat of what I asked them in 5 minutes about on the policy roundtable. But if you have questions for them, please feel free to pose them. Yes, Stephanie.
I guess mine's more of a comment. I just keep going back to this pie chart. And so the purpose of these ultimately is to prevent people from becoming addicted and not, and so prevent death. So if we look at these 153 people that were entered into a substance abuse program, only 3% of them said that they stopped abusing the drug with that formulation. A third of them replaced it with other drugs. A third continued using the abuse deterrent form, and a third it didn't matter. So for me, because that is ultimately what we're trying to do from a population perspective, this speaks a lot to me. So I'm going to vote no for those reasons.
So, Stephanie, just a comment on that. That's people who are into an abuse program, which is very different than people who are beginning to get into, starting to. So, OxyContin and other ADFs may prevent people reaching that point. So the ones who are already addicted, yeah, only 3% quit. But if you can stop 99% from starting, you've made a big difference. So I'm going to vote yes.
And I hear that, but I guess I haven't seen data to show that these products prevent that from occurring. And just remembering that at the end of the day, we're using opioids. And so 10% of the population, regardless, are going to be genetically susceptible to addiction.
Other comments or questions? Again, it's helpful to hear people's thinking about their vote. Sometimes it's very...
The other issue, I think, is if you're talking on a population basis, then you're including the diversion issue,
yes,
and which is the big elephant in the room, and not the patient issue. And as to whether OxyContin has effect on the effects of diversion, which still is 50-something%, is and whether it somehow changes the dynamics of the narcotics abuse has to be taken into consideration.
Okay, ready to vote? All right, please do. Ten, no, 2 yes. All right, that's a good starting point for our policy roundtable. And we will come back to the fourth voting question at the end of the policy roundtable, where we'll be making some policy level choices based on the discussion and the evidence. So thank you. Everybody who's up at the table can stay except for the ICER folks. And I'd like to invite up the other, I think we have maybe just 1 or 2 other, no, 3 other members perhaps for the policy roundtable. Yes, Dr. Cohen.